All right, well, welcome to this pharmacology review on the drug class loop diuretics. I'm Dr. Busti, your faculty and host on This Is Why, a show where I help other healthcare professionals transform medical knowledge from what to the why. With 30 years of experience as a nurse, pharmacist, physician, and academician, I help healthcare providers connect the dots for a deeper level of understanding, which enables us to understand the why we do what we do in the management of patients. Now, the loop diuretics go back to the 1960s. Interestingly, this class evolved out of the research on the thiazide diuretics that date back in the 1950s. The first loop diuretic that was introduced in the mid-1960s was Furosemide. This was followed by a growth of agents in the 1970s and 1980s. And currently, this drug class represents around 26 million prescriptions per year, with the majority of them centered around one agent. That's right, the first one in the class, Furosemide. You know, over my 30 years, I administered this class of medications as a nurse. I've approved it, dispensed it as a pharmacist, and I prescribed it as a physician. It's also one of the first drugs early in my career where I asked one of my course faculty way back in the day, why does furosemide cause hypokalemia? I had been memorizing things and found it less interesting and harder to remember. And so when I started to figure out the why, I found myself being able to shift the learning to understand, and I was able to retain it more. Well, that's our goal here. And just like with other pharmacology reviews, I want to make sure that we're all on the same page. This is meant to be an overview of the drug class itself. It covers that core knowledge. And at the same time, we want to transfer that core knowledge into some meaning. We want to make it easy to understand. We want to make it clinically relevant. We want to orient it to the patient in its proper context of known evidence. Well, given that, and start off by asking ourselves, why is it relevant to learn about the loop diuretics? Well, I can tell you as a clinician, again, for the past 30 years, having a medication that I can use in the inpatient and outpatient environment to manage fluid overload and true edema. And I'm talking about where you need some decent diuresis. You got to get rid of this fluid. The loop diuretics are the class of drugs that meet that demand. And that is huge. They've been around for decades. We're very comfortable with it. They're not perfect, but that diversification in its application in the inpatient and outpatient environment is good for clinicians, but it's also good for patients, because patients start to get familiar with the medications that they're being given, prescribed, and counseled on. And so that is one of the reasons why we're spending our time, plus recognizing that, as I said a little bit ago, this drug class makes up a fairly significant amount of prescriptions dispensed each year. All right, now we need to jump into, well, what medications make up this drug class? And it is relevant that while we focus our review on the generic names of these medications, some of them not only have historical, but sometimes they change brand names based on formulations. That's happened in this class. It's still ongoing sometimes, occasionally, and some go and some stay. But it's important to recognize that sometimes a brand name of a product may correspond to a dosage formulation or use. Now, board exams are going to use, generic names. Most people are going to remember it by their generic name. And so that's what we're going to cover. So those drugs are Bumetanide, Ethacrynic acid, which some people may not have ever even heard of. I've known it for most of my career. I have never once seen anybody ever take it, receive it, or I need to order it. But it is technically a loop diuretic. Furosemide, and then lastly, Torsemide. Now, Based on the relevance that we just mentioned a minute ago and the medications we just listed in this class, what are the indications or common uses for why they're used? And I'd like to jump to a table to summarize that. All right, so here's our table. This is a table that we'll see in other drug class reviews and other topics on the diuretics. And I think it's important to learn drugs and drug classes in the context of other agents that have a similar impact, so other diuretics. Why do we pick one class of drugs over another is in part based on the indications and use. Now, all the indications listed here or identified here with check marks don't necessarily mean that they're all FDA approved. That's all right. I mean, we know we use drugs off-label all the time. Now, this is not meant to be a very comprehensive, overall exhaustive list of every potential scenario that could be used, but the most common, okay? And so that's what it's meant to be. So the highlighted area here in the row, the second row here, is the loop diuretics that you can see. That's the ones I'm referring to. I did not include ethacrynic acid there because, again, it's just reserved for patients with an allergy. Very rarely used. But I want you to compare it to the thiazides, which is right above it, and then mineralocorticoid receptor antagonist below it, and then the less commonly used potassium-sparing diuretics, followed by even more or less commonly used carbonic anhydrase inhibitors. You'll find that the carbonic anhydrase inhibitors, like acetazolamide, are primarily used for things like mountain sickness or high altitude sickness, intraocular pressure reduction, and patients with intracranial pressures from usually pseudotumor cerebri. So very unique indications for some of these drugs, and those are great test questions for board exams. They're usually great questions that preceptors and faculty like to ask on bedside rounds, those kind of things. So pay attention to some of those. Now, as it relates to loops, you can see that furosemide in particular is listed under the column for ascites, and that's patients with underlying cirrhosis with fluid accumulation in the peritoneum. These patients many times will be administered on high dose spironolactone, which is actually a mineralocorticoid receptor antagonist. And that high dose of spironolactone can cause hyperkalemia. We use that high dose spironolactone in the management of patients with cirrhosis and ascites for a very specific reason I'm not going to dive into today. But the risk of hyperkalemia warrants something to get rid of it. We don't want to accumulate too much potassium. So we give the loop diuretic, in this case, not to get rid of so much the fluid, but rather to reduce the risk of hyperkalemia associated with the high dose of spironolactone in the context of ascites. Obviously, edema is going to be an indication. That one's pretty intuitive and makes sense. Heart failure, typically heart failure from systolic dysfunction, where they usually are suffering from fluid volume overload, okay? And then the next would be, you see listed here, hypertension. You're like, what? I don't see people being managed with hypertension on Lasix or other loop diuretics, and you're right, because we have too many options now to treat hypertension. We don't, and we shouldn't, be using loop diuretics to primarily manage patients with hypertension. But early on, when they first were coming into the market and available, we didn't have as many drug options as we do today. Again, remember, in 1960s and early 70s, some of these drugs started making their way. So that was a long time ago. And so as the evolution of drug therapy has come along and we've improved it for a focus on hypertension, we don't use these drugs. However, this should raise a note for you. Well, if they used to be used for hypertension, that means that they could lower blood pressure. And they can do that based on their mechanism. And you do need to watch out, because over-diuresing a patient with any diuretic of any class can cause plasma volume shifts that reduce stroke volume, that also reduce cardiac output, and eventually reduce the blood pressure. So it is relevant. It's just not what we're using to primarily target hypertension. So tables like this are available at thisiswhy.health for those of you that are interested. They sometimes can be great study tools if you're a faculty or preceptor and want to use them for bedside teaching or your lectures. Feel free to do so. All right, so the next thing that we need to discuss is the mechanism. And this is where the what, or that descriptive, explicit knowledge, that stuff we have to memorize, starts to make sense of the why for everything else that follows. And that things like side effects, potential drug interactions, monitoring parameters, counseling points, points of efficacy. So how then do the loop diuretics and their indications connect to make sense of the mechanism of action? Okay, so now in order to make sense of the mechanism of action, we need to, in this case, and specifically with this drug class, consider some of the anatomical factors that may impact the drug's delivery to the site of action. I don't care what a drug does in a lab, I care what it does in a patient. And so when you administer it IV or by mouth, it has to go somewhere. And in this case, we need to get it to the kidneys, okay? That means one of the ways we get there is by perfusion. So I like to stop for just a quick second and orient to the basic anatomy, especially in the context of blood flow, because it's an essential component to the way the drug works, getting it to its site of action, but also the degree of efficacy that we see and the variations that sometimes come when that blood flow is being altered by some other problem, like say it's like heart failure. Now, Bro, who's one of my old residents, just kidding. Bro, we like Bro. He hangs out with us. He's got glasses. But, you know, we like to use him and take his body parts to teach these points. All right, guys, just kidding. Having a little fun here. The kidneys and the bladder and the ureters anatomically sit in this area. And it's important because this is also where patients exhibit symptoms when they're having problems with their kidneys. Their back, that CVA or flank tenderness becomes very real, right? But anatomically, you can also see, even with trauma, why we would be concerned about the kidneys. But look at these blood vessels, where they're coming from. Well, the heart is sitting up here, obviously, and is that cardiac output. 25% of the cardiac output with each beat goes to the kidneys. That's a lot, a fourth. So there's a lot of other parts of this body that need to get perfused, but the kidneys are certainly getting a lot of attention. So we need volume, but we need blood pressure, we need perfusion to those kidneys. So when we start to look at the anatomy, sorry bro, I'm taking your parts here. They're gonna be good use, right? We have the left kidney, the right kidney, we have the inferior vena cava, but we also have the aorta. Remember the ascending aorta curves, aortic arch, and it comes down to the descending aorta. This is where abdominal aortic aneurysms occur. These can develop weakenings in the wall and that kind of stuff. You see a lot of branches coming off. They go to different organs, the intestines and other things that have been removed here. Then we've got perfusion to the kidneys, okay? You also see that within the kidneys, we have these two things on top. Those are adrenal glands. That's where aldosterone is released. That will also impact the kidneys as another form of a diuretic. It's one of our mineralocorticoids. It helps to retain sodium plus water. Okay? So it can be a reason for secondary hypertension, hyperaldosteronism. You also then see the ureters drain down into the bladder and eventually then would be eliminated. When we look at the kidneys and we take a cross section of the kidney, I'm going to grab a larger version of Bro's kidney here. You see that there are blood vessels coming in and there's blood vessels exiting. Okay. You also see that as those blood vessels go in, they branch down to small vessels. Where are they going? They're trying to get to the nephron, which is what we're getting ready to talk about in more detail. But the drug has got to get to this organ and has got to get inside of this organ down to that nephron in order to have any ability to make an effect and cause a diuresis. Okay. If we get some decent blockage of the transporters in the nephron that we'll talk about here in a minute, then we're going to see more volume coming out, entering into the renal pelvis and down into the ureter. So let's now stop and take a moment and let's dive into the little details right here in this area as it relates to the nephron. So here's a classic nephron down at the tissue level. You can't see it, microscopic, but there's a lot of these present in the kidney. But you see these blood vessels coming in and exiting, and specifically the arteries perfusing that glomerulus. That is where the Bowman's capsule is. This is where a lot of filtration occurs. What is being filtered there? Water, sodium, glucose, bicarb, other things. But a lot of things get filtered there. This is a big filtering membrane to concentrate and help us to regulate electrolytes, water, and fluid balance, which is why when people don't have kidneys, they need an artificial kidney system like dialysis, okay? Now, you also notice that there's the beginning stages. This is the proximal renal tubule right here, okay? Now, as urine filtrate moves to the proximal renal tubule, it will then enter into the loop of Henle. And there's a lot of free water reabsorption going on here, concentration of there's gradients. It's hard to show it all right here, but just understand that it's very detailed. But you see a lot of things that are influencing the urine filtrate, and then it approaches the thick ascending loop of Henle. Then it eventually makes its way to the distal convoluted tubule, and then it makes its way to the collecting duct. Now, the collecting duct is pretty much the last effort for water to be reabsorbed. And so you see a lot of free water being absorbed at this level. This is where urine is being concentrated. So if you're out in the desert and you're sweating or you're doing a lot of manual labor and losing lots of fluids, your body is going to try to hold on to that free water. So it's going to increase antidiuretic hormone and you're going to suck in that free water. Okay? Now, let's go back to the neuron. Approximately 60% of sodium that's filtered into this area is reabsorbed. At the thick ascending loop of Henle, about 20 to 40% of sodium water is being reabsorbed. At the distal convoluted tubule, about 5 to 10% of sodium and water is being reabsorbed. Why does it matter that? Okay, well, it matters because we have drug therapy that targets this area. We have drug therapy, in particular the loops, that target this area. We have drugs like thiazide diuretics, but also potassium-sparing diuretics, and even mineralocorticoid receptor antagonists that start to impact this area. All of those things are working as diuretics from varying degrees for various uses and benefits on minerals and electrolytes to create a desired effect. And that's why we pick an agent or type of diuretic for a specific indication. Okay, so now at this point, we've talked a little bit about the blood flow from a gross anatomy standpoint into the kidney. We've narrowed in to the nephron, looking at that. Let's take a step and get to the glomerulus. And you're like, well, why are you spending so much time on this? Because the drug has to get to the site of action. If it doesn't make it to the kidney for hemodynamic reasons, it's not going to do anything. Once it makes it to the kidney, it still has to get inside of the nephron, the renal tubule. So it has to get moved across cell membranes and put inside of this tubule system. It works on the tubular side, or what is called the apical membrane side of the lumen. Without it getting there, it's not going to work. I don't care what it does in a lab. I care what it does in a real patient. And these things influence, the normal anatomy and physiology influence the way this drug is going to work. It also impacts the way you dose it. It impacts the way we use the drug. Sometimes we give doses intermittently. Sometimes we put them on a continuous drip, IV, for a reason. Those are all the reasons for doing that. The why goes back to understanding this. So if you can understand why this stuff matters, then those things make sense. All right, now let's dive into the glomerulus. So here we are, again, we're zoomed in this very small area of the kidney, specifically looking at the nephron, and we're right here where that renal afferent arteriole is coming in. So remember, 25% of our cardiac output in normal situations, under normal conditions, is roughly going to the kidneys. That means that the kidneys are important for a reason. So we have blood vessels coming in to the glomerulus. Those are called renal afferent arterioles under the influence of a number of chemical mediators that are endogenously made. Things like the sympathetic nervous system, angiotensin II, prostaglandins, bradykinin, nitric oxide. All those things influence the diameter or the level of constriction that regulate blood flow coming into the glomerulus that then impact the overall glomerular filtration pressures generated. Why does that matter? Because pressure is going to push things into the Bowman's capsular space. This is where the earliest stages of urine filtrate are made. This is also where things like sodium, water, glucose, bicarb, like I said before, get put in here. So they dump into this area. Now the drugs, like loop diuretics, are not put in there like that. They have to make it on and go into the efferent arterioles and enter the peritubular capillary blood vessel network, which is close to the nephron. But we need the drug inside of the nephron tube. So this is where drugs, and there's a lot of drugs that get put in here, a lot of chemicals, even like uric acid and beta-lactam antibiotics, things like that, they get put into the kidneys for elimination. Okay, well in this case, we got to get it in the kidneys to work. So the loop diuretic. So this blood flow through here and this presence of that is essential for the drugs to work. So you can imagine if we take away nephrons or we reduce the blood flow into the kidney, we're going to therefore reduce the efficacy of the loop diuretic. I mean, it's not rocket science. It makes sense, right? So let's now move into the proximal renal tubule and see what's going on about getting that drug in the space. I know this is a lot to absorb when you first see it, like, oh my goodness, Dr. Busti, like, what are you showing me? I don't need a seizure right now. There is a lot going on in the proximal renal tubule. I'm not even doing full justice to it. Just going to say that right now. There are a lot of other transporters, influx, efflux transporters, changes in the permeability, all these things happening. There's a lot going on in that proximal renal tubule. Remember, that's where the earliest stage of the renal urine filtrate is being made and starting to be formulated in its final form. So very early on, sodium is important, which was, remember, part of the filtrate. Water is very important for a number of reasons, okay? Glucose is being reabsorbed, especially if you can, not too high, right? This is where patients with diabetes suffer from polyuria, polydipsia. They spill too much glucose, and the sodium glucose transporters, SGLT2 transporters, cannot absorb enough. Right? Typically, when you get over 180 milligrams per deciliter, they just can't do it, so it just spills out. All right, but we've got efflux transporters, uric acid transporters, all this stuff. Well, let me orient you to the proximal renal tubule. So there's early cells in the proximal renal tubule, and then there's late. You're like, okay, why does that matter? It matters because the distribution of transporters shifts as you go down in the nephron. It's going to change when you get to the ascending loop of Henle. They're not all the same in all locations. It has to do with that purpose of that geographic location. So that's one of the reasons why I mentioned that. Number two is, remember, you see that we have the lumen or tubular side, and there's the apical membrane on the tubular side. Then there's the interstitial space, or where the blood vessels, that peritubular capillary network system, is on the basolateral side, if you will. So remember that the loop diuretic is coming in from the efferent arteriole, and here it is. Well, it's got to get over here. Well, it does that through these transporters that are influx and efflux cell membrane transporters that move things across cell membranes that can't just diffuse for charge reasons, size, whatever, right? It's complex. And again, like I said, I'm not covering all of it. I'm just giving you a snapshot of some of the key points. That's it for this purpose of this lecture. But you've got to get the drug in through the cell and into the renal tubule as part of the ultimate renal filtrate. Now remember, this is the proximal renal tubule. So now we need to head into the loop of Henle. But before we do that, I want you to recognize that uric acid is also over here. Uric acid also uses some of these pathways, and sometimes there's like traffic jams. They compete, block each other. And so you can raise the concentrations of uric acid or change them. And so that can sometimes be important for patients with underlying gout, for example. Okay, let's now move on to the next step. So here we have the urine filtrate. Here we just left the proximal renal tubule. We now enter the descending loop of Henle. Now we're entering the ascending loop of Henle, and we're now approaching the thick ascending loop of Henle, which is right here. So the urine filtrate is coming in. The loop diuretic is with it. Boom. Here is the transporter that the loop diuretics are focused on. So they work on the ascending loop of Henle, the thick ascending loop of Henle. They work on the sodium, potassium, 2-chloride transporter. Some people use the word simple transporter, those kind of things. But the point of the matter is this thing does a lot. It's moving all these charged molecules across cell membranes. And then you see we have on the basolateral side other membrane permeability shifts or transporters like the sodium potassium ATPase pump that are now going to keep moving again. Remember, 20 to 40% of the reabsorption of sodium right here occurs at this level. So if we block this, then we theoretically can block up to 20 to 40% of sodium reabsorption. Well, what follows sodium? Water. So now that sodium stays in the tubule and the urine filtrate, and is going to now make its way up towards the distal convoluted tubule. We'll talk about that in a second. Now, you see that there's also the ability to block reabsorption of potassium. Well, this is why you can lose potassium. You can also block chloride. This is where sometimes acid-base disturbances eventually come with too much use. You can certainly lose sodium and develop some degree of hyponatremia. But you also see there is some other cations, divalent cations in particular, the magnesium, calcium over here, that are being reabsorbed in a paracellular manner. Well, what does that mean? Well, remember, these are charged. You see all these charges shifting around? Well, that creates a difference on one side of the membrane over the other. And part of the system wants to do is keep things somewhat degree in balance. And so when you change the positives, the negatives do something different, and vice versa. So when you give patients a loop diuretic and you block this, you also block some of the paracellular reabsorption of magnesium and calcium. And so why does that matter? Why do you need to know that? Well, there are additional electrolytes, by the way. Sodium, potassium, calcium, magnesium all play very critical roles into cardiac function, including intervals on an EKG. If you decrease all of those electrolytes, you can prolong and start to widen the QRS and prolong the QT interval and set these patients up for torsades. So if you remember, like the treatment of torsades is magnesium. So Any of those electrolytes in low concentrations can prolong the QT interval and increase the risk of life-threatening dysrhythmias. So that's why it matters. But it also matters for another why. When you start to lose that potassium and you're losing magnesium, you create a bad pattern. You need magnesium at the cellular level to regulate the intracellular concentrations, and i.e. total body potassium levels. You need that magnesium to do that. So without the magnesium, you cannot fix and regulate the total body potassium concentrations inside and outside of the cells. That's very relevant. Why? Because if you just check the potassium and you see, oh, the patient's on a loop diuretic, their potassium is going low because I'm making them urinate it out, I'll just give them more potassium, and you don't bother checking the magnesium, you will not find that you'll have a very hard time correcting the hypokalemia. In order to fix the potassium losses, you have to first fix magnesium losses if they're present. Well, the problem with magnesium is it's not part of a basic metabolic profile. It's not part of a comprehensive metabolic profile. You have to order it separately, and most people don't do it. I can't tell you how many people I find, and I practice in the emergency department, who come in and have hypokalemia, and I check it. They're always seem to be deficient in magnesium. So it's very relevant for you to do that, not only for cardiac-related issues, but it's good. You need magnesium in other places of your body. You need calcium in other places of the body as well. So calcium can be lost as well. Well, why does that matter? Well, that matters because some patients who develop hypercalcemia, specifically we see this in cancer patients where bone is metastasized, or as cancer is metastasized to the bone, and it causes this resorption and this spilling out of calcium into the blood. People want to get rid of that calcium. Well, that makes sense. You don't want it calcifying everywhere. But the treatment is high dose or use of lots and lots of IV fluids. Well, I can also get rid of some of it by using a diuretic like loop diuretic. And because you can get rid of the calcium here, the problem with that is it's not the right way to deal with it, the problem. You need to deal with the metastasis to the bone and the bone resorption, usually with the bisphosphonate, but fluids. Now, we may have to give loop diuretics in that case to get rid of the fluid because we don't want it to start accumulating in their lungs. That's a lot, right? You can see that these drugs have a really good diuretic effect, but boy, they can cause some issues, and that's why sometimes there are nuances in how we use the drugs in clinical practice. When you understand that why, it makes sense of the how to do it and use it. Now, as we go into the distal convoluted tubule, remember what's happening to the urine filtrate right here. It just passed the ascending loop of Henle. It's got a lot of sodium and water. So as it comes up here, the distal convoluted tubule cells over here go, whoa. There's a lot of potassium or sodium coming in the tubule here. Is that normal? Or hey, whoa, what's up, guys? Let's get some of that stuff in. Well, remember, the normal is that, that 5 to 10%. So this is not a big location for a lot of sodium reabsorption. Remember, you're just trying to fix the final urine filtrate before it enters the collecting duct. So that's why thiazides tend to have a more mild diuretic effect compared to the loops. They're blocking that sodium chloride, not potassium, sodium chloride symporter or co-transporter. There's no potassium here. Now you can still lose potassium. That has more to do with shifts over here on this side. And then also distal, there's another effect I'll show you here. We turn the corner. So now it comes over here and it makes its way out. But as I was saying earlier, when you take chronic loop diuretics and you keep delivering all that concentration to that distal convoluted tubule, you run the risk of causing diuretic resistance with chronic use. That means you might have to increase the dose over time to overcome compensatory changes compensatory changes in this tissue of the apical membrane. What that mean by compensatory changes, you might upregulate more sodium chloride co-transporters. Well, if there's more there, then you're maybe reabsorbing more than 5 to 10%. Maybe it's 15, 20%. And so you start to lose the diuretic effect on the standard dose that had worked before. That's a pharmacodynamic impact. That's like tolerance, if you will, right? So we call it diuretic resistance, but it's kind of this compensatory tolerance you develop, so you have to increase the dose. Or you have to do something to block this transporter from working. And that's why some people would administer selectively, very carefully, a thiazide on top of a loop temporarily to get rid of fluid. You don't want to do that too much because you can over-diurese the patient, but it's very relevant in the context of diuretic resistance. Now let's make our way over to this last little step before they enter the collecting duct. All right, so we have the distal convoluted tubule. It's headed right towards the collecting duct, and there's this last little ditch effort here for us to regulate sodium and potassium. This is somewhat under the influence of aldosterone, which is our mineralocorticoid receptor, or mineralocorticoid. It turns on genes that regulate some of the changes in permeability and reabsorption of sodium here. This is also where free water is starting to be reabsorbed and concentrating the urine, especially if we're needing to hold on to it. So these are your last ditch efforts before you enter into the collecting duct, where mainly it's just urine filtrate concentration that is occurring. So loop diuretics, you're going to see a lot more sodium and water being delivered. That means it'll make its way into the ureter. Now, with all diuretics, you're losing volume. Some are going to cause it more than others, but you're losing volume. Volume is reflective by preload. That's one of the hemodynamic parameters that regulates our blood pressure. So let's take a moment to look at the formula of blood pressure so you can see why the use of these drugs, especially given IV push too rapidly, can sometimes cause hemodynamic shifts in the patient. All right, so blood pressure up here equals the cardiac output times the systemic vascular resistance, or sometimes we refer to that as peripheral vascular resistance. It's the same thing. Now, cardiac output is equal to heart rate times the stroke volume. So if cardiac output is to stay the same, but one of these variables changes, the other one has to compensate. It's just a mathematical equation, that's all it is. But stroke volume is influenced by that preload. That's the volume, force of contraction or inotropy, and then the afterload, or that resistance to forward flow. But resistance. So diuretics over here all decrease the preload. So as you decrease the preload, you decrease the stroke volume, you decrease cardiac output. That can, especially when administered rapidly, mainly IV push, can cause hemodynamic instability. When you administer it by mouth, yes, of course, you're going to lose plasma volume over time. You're going to diurese the patient. Your preload can go down, and your stroke volume will go down. That will decrease your blood pressure. That is why, and we remember back from the indications that this drug class was initially used in part to manage blood pressure, because you're impacting the blood pressure. Okay, so that's the main mechanisms, and those are the things that should start to, form some thought process together as to the next steps of things you need to do clinically. All right, so you saw from the mechanism that hopefully that makes sense of the indications, especially as it relates to edema and fluid volume overload, especially in patients with heart failure, but even extending over to blood pressure. But you heard me say the importance of drug delivery. Well, this impacts and is influenced in part by the pharmacokinetics and dynamics. This impacts the way we use the drugs the way we do. So what are some of those specific pharmacokinetic and pharmacodynamic parameters that influence the way we use loop diuretics the way we do. Let's dive into a table that I've put together for you that summarizes some of these. And again, I like to learn things in the context of tables because you compare one agent to another. It helps you to wrap your mind around, why do I pick one drug even within a drug class over another? That's also understanding a drug class helps you to say, well, why do I pick this drug class and this agent inside of this drug class over another agent from a different class? It really, a lot of it stuff comes down in part to some of these things. So over on the left side, you can see that we have the pharmacokinetics, and then we have down at the bottom the dosing considerations. Now, there's a number of things that I want to point out individually about those two sections. But first, let's say you see that you have Furosemide, Bumetanide, and then Torsemide. Let's step into the pharmacokinetics and first start off talking about bioavailability or absorption. You can see that Bumetanide, Torsemide in particular have pretty decent and almost 100% oral absorption. That means that when you administer it by mouth, all of it makes it into the body or most of it. But when you look at furosemide, you can see that 30 to 50% of the drug that you give by mouth basically never makes it into the body. It just is lost in the stool, right? That matters because anything that compromises the absorption in the GI tract will then influence the drug that's delivered to the kidney. So you can change the overall efficacy by preventing the absorption in the gastrointestinal tract. What things could do that? One of them is the edema in the wall. Remember, these patients have fluid volume problems. That's why you're partially using and mainly using this drug class to get rid of edema, get rid of extra fluid that shouldn't be there. Well, that may be fluid that you can see, like in lower extremities, and they have edema. It might be fluid in their lungs that you can hear on exam. But if you open them up and you look at their intestines, they can have gut edema, okay? And that can compromise the absorption. Well, if I want to not have the gastrointestinal tract be an issue, what can I do? Well, I can either give a drug that has better absorption and maybe less influenced by gut edema, like bumetanide and torsemide, or I just bypass the whole gastrointestinal tract and just give it IV. They don't have to worry about what's in this intestine. Again, some of this is that reason of why we switch from an oral to an IV or a specific situation in the hospital or in the severity of the patient's condition that may drive us to pick a certain drug dosage form. Food also seems to impact a little bit of the absorption, specifically with furosemide and bumetanide, but not so much with torsemide. Again, none of these things are like absolutes, perfects. There's, again, some degree of influence. It's going to be hard for you as a clinician to determine what degree of, bowel edema and what degree of food impacted the overall efficacy. Right? We get this stuff off of pharmacokinetic studies that are done where we manipulate one environment and we can go, okay, well, that impacted this. But what is it doing for the real patient in front of you who you're managing in real world clinical practice? That's very different because there's a lot of other things that can go on. So there's a ton of inter-patient variability. That means the dose that I use in one patient may not exert the same effect as the same dose in another patient. And so that's why the inter-patient variability is high with furosemide. Not so much with bumetanide and torsemide. You're like, well, why is furosemide used so much then? Well, it's just cheaper, right? It's what people are familiar with. It was the first drug in the class, so you get used to it. You accommodate for these limitations. But when someone's on bumetanide, torsemide, there's a reason they're on it. It's usually for some of these pharmacokinetic things that are impacting the overall efficacy of the drug as it relates to getting to that site of action. When you look at the half-life and the duration is important to recognize here. It says 6 hours. So the brand historical name of furosemide is Lasix. last 6 hours. So that's where it got its, name from in part, is based on the duration of action. Well, that's under normal conditions, situations, and all that other stuff. They may not last at all near 6 hours in some patient populations. And this is where the duration or frequency of administration starts to play into how and why we manipulate the frequency in one patient differently than another. It really comes down to what is the effect that you're getting in the patient you're serving, you're treating, you're managing, which is different from another patient. So that interpatient variability being high, you are adjusting it based on the effects that you're looking for and the desired outcomes that you're trying to achieve. And so that will look differently from one patient to another, and that's okay. But you need to be able to articulate why that is the case. You may need to be able to communicate to that patient or to your other members of the healthcare team so that they also understand that as well. Now you can see that Torsemide has a longer duration of action. Again, this allows for much easier, less frequent administration. Now, I do want to point to the next thing, which is elimination. So we have absorption, distribution. Again, this is getting distributed to the kidneys. Metabolism. Well, you don't see any rows here listing phase 1, phase 2 metabolic pathways that involve the cytochrome P450 or conjugative pathways. You don't see that. You see renal elimination. Well, that goes back to the mechanism. Remember, it's got to get delivered there. It's got to then get secreted into the proximal renal tubule in order to work, period. So it's a renal tubular secretion methodology of elimination in the body. And again, those transporters include OAT, probably also includes MRPs on the other apical membrane side, but that's what you'll see when you look at some of the sources. Do you need to memorize all that? Probably not. You just need to know really that transporters are moving this drug across the cell membrane at the proximal renal tubule and getting it in to that tubule at the proximal side of the nephron. Now, if the nephron is dead or you've got a lot of acute tubular necrosis and kidney injuries and acute renal failure, well, you may not have very many nephrons that are going to let you do that. So the overall efficacy is lost. The drug might be getting there, there's just not enough nephrons to impact the fluid volume control that you need. So tubular secretion is a main route of elimination in the body. That means that as the renal function is lost and impaired, the effect and that duration of action is going to be compromised. That's why. I hope that makes sense. It should. Okay? You don't have to memorize that. It just starts to puts things together, connects those dots like we talked about. Now let's look at the dose. This has to do with potency. This is a pharmacodynamic property. How much drug do I have to administer to exert the desired pharmacologic effect? So if you were just to look at the usual doses that are listed here in this row, so it's up to 160 milligrams of furosemide, up to 4 milligrams of bumetanide, and up to 80 milligrams of torsemide. Those are very different numbers. Much bigger with furosemide than bumetanide for sure. Well, what does that mean? Well, that tells you that bumetanide out of these three agents is the most potent. Now, that doesn't mean it's the best or most effective. It just means that I have to give very little amount of this drug to exert and get the desired pharmacologic effect. So that means if I want to get the same effect with furosemide, I just have to give more because it's less potent. So the potency is bumetanide first, followed by torsemide, followed by furosemide being the least potent. So I have to give more milligrams. Again, why does that matter? Why am I wasting my time talking about it? Because you have to sometimes articulate to other members of the healthcare team that may not understand that, they may not have that training, but you also need to talk to your patient. They may look at those milligram strength and go, I'm not taking that. That's way too much. Or why are you giving me so little of this drug? That's natural for them to ask, and quite honestly, intuitively starts to make sense from a layperson perspective. But it's really centered around that potency. And potency doesn't necessarily mean better. I mean, we think of that word and we sometimes think potency is better, but in reality, it's just the amount that we have to give. Now, why does that matter? Well, it matters because it impacts your equivalent dose if you need to convert somebody. So what does that mean? Well, let's say most people are on furosemide. We've seen that it has a lower absorption. It's more variable from one patient to the next. It's influenced by food, blah, blah, blah. And let's say we're not getting the effect that we want and we need to switch them to bumetanide. Well, how are we going to do that? To get them to that ballpark dose that they need to start on. Well, you take the total daily dose of the furosemide that they're on and you would divide by 40. Now, you see, it's not perfect. It's an approximation. It's an estimation. But it gets you a starting point that you may then have to still adjust to get that effect for that patient. But it's an appropriate way to convert from one agent to another. Let's say you wanted to go from furosemide to torsemide. Well, you would just take the total daily dose of furosemide and divide by 4. So it's not as potent as bumetanide, but you still need to reduce the amount that you would give in order to exert the same effect and start out close to equal, right? Now, again, it's not perfect, not an exact science. Don't treat it like that, black and white, okay? Every patient did, because there's so many other things going on up here that also impact the efficacy, not just the dose equivalency. Now, this all points to also the PO to IV conversion. This goes back up to our oral bioavailabilities. Well, drugs that approach 100% by mouth, well, the milligrams you gave by mouth is the same milligrams you would give IV, 1-to-1. But when you look at furosemide, most cases, if you're giving an IV, it's half the oral dose. Because again, 50% of the drug never makes it in the body when you administer it by mouth under normal ideal conditions. You change those conditions and make them worse, it might be less, maybe 20, 30% of it only gets absorbed. And the other, 70 to 80% is just eliminated in the stool. Never reaches the blood. Never going to work. So that's where that PO-IV conversion use becomes to make sense. It goes back to the bioavailability. That's where the dose conversion from from one agent to another. That's how you do it. Now, why is there a ceiling effect? A max basically effective dose. You see that's 400 milligrams for furosemide. You see it's 10 milligrams for bumetanide and 200 milligrams for torsemide. Well, these drugs, unfortunately, just like thiazide diuretics, there's a max effective dose. Yeah, you may push it up to a little higher milligrams in a dose. You'll get more bang for the buck, but that bang for the buck starts shrinking as you push the dose. Number 2 is typically as you expose people to more chemical of anything, there's going to be a side effect at some point. Well, in this case, it is ototoxicity. So basically hearing loss. That's going to be more pronounced if you have a patient who's already taking an ototoxic drug. Think about like cisplatin, aminoglycosides, vancomycin, right? There are drugs that are known to do that. So you've used 2 or more agents, that risk is going to go way up. Okay, and so that becomes very relevant. Okay, so we all know, again, that drugs have side effects. Monitoring parameters, drug interactions, nothing's perfect. We know that. You've already seen and just heard me talk about a side effect, ototoxicity, ceiling effect. But what are some of the most common side effects and adverse drug events that occur with the loop diuretics? Well, again, go back to the mechanism. You shouldn't even have to memorize this. It should make intuitive sense to you. That you're affecting electrolytes, you're affecting fluid. So if I were to predict what a contraindication would be, well, if I'm not making urine, there's a problem with my kidneys. I mean, it's not rocket science. So a patient who is anuric, not making urine, a loop diuretic probably is not going to help them. It may actually make things worse or expose them to side effects that are unnecessary. I can also over-diurese the patient and cause so much fluid electrolyte depletion that I cause cardiac instability, hypotension. I even put them in acute kidney injury because I hypoperfuse the kidneys. So it should begin to make sense. But let's look at a table that helps us to look at the electrolytes in particular. Because remember, there was a lot of electrolytes being impacted by the loop diuretics in the thick ascending loop of Henle. So in our table, again, this is our drug classes, the thiazides at top, loops, followed by the aldosterone antagonists, also known as mineralocorticoid receptor antagonists, our potassium-sparing diuretics, and then lastly, our carbonic anhydrase inhibitors, and what they do, the impact on diuresis. You can see that loop diuretics have a pretty decent amount of diuresis. Okay. You can also see that we have sodium loss, but remember, we're affecting sodium at 20 to 40% of reabsorption in a thick ascending loop of Henle. But it's less than the thiazide diuretics. Why? Well, because remember, you still have the opportunity to reabsorb that sodium in the distal convoluted tubule, whereas with thiazides, once it enters the collecting duct, it's lost. But potassium losses, magnesium losses, calcium losses, chloride losses, again, go back to that thick ascending loop of Henle. You have that sodium, potassium, 2-chloride transporter that you're blocking. You're also blocking or impairing the pericellular reabsorption of magnesium and calcium. That is a lot of electrolytes. And remember, it can also affect other organ systems. Your brain needs sodium. It also needs calcium to release neurotransmitters. Your heart needs sodium, potassium, magnesium, calcium to regulate intervals and electrical current going through, especially nodal cells and cardiac tissue. And so this is where if you deplete these levels, especially all of them, you can cause significant cardiac dysrhythmias. In particular, prolongation of the QT interval and widening of that QRS. That can lead people to torsades or other ventricular malignant conditions that are life-threatening. So it matters. And you heard me say that when you lose magnesium, your ability to regulate and maintain potassium is lost. So you would just have these compounding potential problems. I know I'm not selling you on using loop diuretics, but my goodness, you need to pay attention to this stuff. Now, if you pay attention to it, no big deal. Well, guess what? Since potassium is lost, guess what? So we have a thing that we do in clinical practice. For every 40 milligrams of furosemide equivalent or furosemide you use, a patient's probably going to need about 10 milliequivalents of potassium. We just give it to them. We know we're going to lose it. Now, you need to still check labs, basic metabolic profile, comprehensive. Yeah, you still need to do those things. But you can preemptively go ahead and start replacing them with it, and that's how we do it. So every 40 milligrams of Lasix or Lasix equivalent, you need about 10 milliequivalents. Now, again, that assumes you're not having low magnesium or hypomagnesemia. So just watch out for those things. The other thing is that bicarb can go up. This is usually from free water loss. And this is where they can develop what's called contraction alkalosis with over-diuresis. I don't have time to go into that in full detail. We'll cover it in another topic review and medical rounds. But it's really important and relevant, especially if you over-diurese the patient. Lastly, you can compete a little bit with some uric acid in the proximal renal tubule. And all diuretics have been associated with a little bit of increase in some degree, thiazides and loops in glucose. Again, thiazides probably a little bit more, but small things probably not as clinically relevant. All right, so we know sometimes that those side effects that I mentioned, adverse drug events, can lead to contraindications. I mentioned one, the anuria, but there is also another one that's fairly common with pretty much any medicine you take, which is an allergy. So what is something that a patient could be allergic to that would explain why you might use a loop diuretic with a little bit of caution? Sulfa allergy. Now, when people say sulfa, What they're really referring to is a sulfonamide allergy. Sulfonamide is a specific type of structural orientation in a chemical structure, which we're not going to dive into here. And sulfonamide containing medications are broken down into those that are antimicrobial sulfonamides versus non-antimicrobial sulfonamides. They are not the same structurally. There's a lot of difference around the sulfonamide group that influences the immunogenicity, I guess, of the drug. So obviously loop diuretics are non-antimicrobial agents. And so the crossover, if you have like a sulfonamide, like the sulfamethoxazole allergy to loop, is very low, almost non-existent. I've never even seen it. Never once. That does not mean that you do not recognize it, and it doesn't mean you ignore it. You just have to keep it in mind. But that was the original reason for ethacrynic acid, because it's the only loop diuretic without that. Now, for those of you interested in this subject and you want to get into seeing the structures and understanding the why of this, I do cover this in a separate topic review in our medical rounds category that's located at thisiswhy.health. So feel free to check that out. But ethacrynic acid, that's its main use. Again, I've never used it ever in my career, been in practice for over 30 years. So there you go. Okay, now all drugs at some level probably have a drug interaction. Some of it can be through phase 1 metabolic pathways like cytochrome P450. That's not the case with loops. It can be also from phase 2 pathways like conjugated pathways, glucuronidation, sulfation, all those things. Not really relevant so much with the loops. Whereas relevant with the loops has to do with anything that changes hemodynamics of the kidney. So heart disease can do that. That is a disease-drug interaction, right? Decreased cardiac output, decreased delivery to the kidney. Now, what about drugs that also depend on renal perfusion? So if I over-diurese the patient, can I impact the efficacy of another drug? Well, lithium is a good example of that. When you lose sodium, you impact the lithium levels. The kidney, they're both cations, so the kidneys are adjusting the positives and the negative charges. And so you have to be very careful because you're affecting the electrolytes that can impact the lithium and lithium risk for toxicity, which is one of the most narrow therapeutic index drugs on the market. Next is digoxin. Now, digoxin's impact and interaction with loops is twofold. One, renal elimination needs to occur. So if you underperfuse the kidneys because you over-diurese them, well, you're not going to help digoxin get released. That's a problem. Secondarily, digoxin works on the sodium-potassium ATPase pump. Sodium, potassium. Two electrolytes that we know, loop diuretics decrease. So when you have hypokalemia, you decrease the potassium delivery to the kidneys. Decrease the potassium available to the sodium potassium ATPase pump. And that makes the digoxin effect more pronounced. More. And that can be detrimental to the patient. So digoxin and lithium are both narrow therapeutic index drugs. And so the risk of toxicity is high with them. What about the NSAIDs? Remember that renal afferent arteriole going into the glomerulus? One of the endogenous mediators that regulate the blood flow in and out are prostaglandins. And well, NSAIDs block prostaglandin production. And with blocking the prostaglandins, you can reduce the perfusion because it causes constriction of that renal afferent arteriole. Prostacyclin, which is prostaglandin I2, has vasodilatory properties. So if you remove it, it constricts. If you constrict blood flow into the glomerulus, you constrict delivery of drugs into the efferent arterial side and down the peritubular vascular network. So dig is affected, lithium's affected, loop diuretics are effective, thiazide diuretics are affected. But also, when you reduce renal perfusion and blood flow, you activate renin release from the juxtacular glomerular cells of that nephron. And that turns on RAS. And the end product of RAS is aldosterone release from those adrenal glands that causes sodium water reabsorption. And in the process of increasing sodium water reabsorption, you increase plasma volume that raises blood pressure and can lead to fluid overload. So you counteract the effect of the diuretic. Also, we know NSAIDs by themselves have been associated with acute tubular necrosis, interstitial nephritis, acute kidney injury. Well, so do diuretics if you over-diurese. So you got two drugs, whammy. So keep those drug interactions in mind. They can be very relevant. That doesn't mean you never can take an NSAID. It doesn't mean you can't use DIG with a loop. We do it all the time. Patients have heart failure, they're on loop and digoxin. Just have to consider the electrolyte problem, and you have to monitor the levels of digoxin. It is what it is. But make sure you know why you need to monitor it. That makes sense. All right, so as it relates to monitoring these side effects, clinical effects we want, but also risk of side effects. So blood pressure makes sense, especially if you're giving it IV push. So we have to administer the drug a little bit slower than we just go in there and just jam it in IV. Right? So usually we give about 10 milligrams per minute. So if you have a 40 milligram dose, it's going to take you 4 or 5 minutes to administer the medicine. Some nurses don't know that, maybe don't want to wait. It becomes very important into the effect. So if you just ram it in, you can cause a drop in their preload and cause a change in hemodynamics. But what else? How are we going to know their fluid status? Well, you can look, check for pitting edema, listen to their lungs, but you can also check their weight. Day-to-day weight changes of 1 to 3 pounds is not fat. That's water. Anything that causes you to shift water, pee more, is going to make you lose weight. Those are the reasons for certain diets and stuff. It's just water weight. It's not true weight loss. But in the context of losing loops, you want to watch their weight. So when they start gaining weight, that means that they're either not taking their medicine, they're dietary non-compliant, or maybe they're developing diuretic resistance, or maybe they have something interfering with the absorption, and now they need a parenterally delivered drug to bypass the GI tract. Okay. Now, what about labs? That's a monitoring parameter. So sodium, potassium. We talked about magnesium, calcium. There's a small risk in the bump in the uric acid. What about GFR? Well, you get GFR by ordering a basic metabolic profile or a comprehensive metabolic profile. Or you can do a 24-hour urine. That's more complicated. But what if you put them into renal failure? If their creatinine starts bumping, well, you probably over-diurese them. They develop contraction alkalosis. You've over-diuresed them. Well, that can lead to decreased renal perfusion and worsening renal function. We don't want that. More is not better, right? There is a tipping point of the amount of diuresis that we want to achieve. All right, so this now should point us to things that we talk to our patients about. So compliance is huge. And it's not just compliance with the loop diuretic, it's also compliance with the potassium. Watching that. If they need it, they need to be taking it with the medicine and know why they're taking that additional medicine with their diuretic. They need to do that daily weight. They need to alert you if they start gaining weight and they are not peeing as much. That is a trajectory of needing different changes in their medicine or a different route of administration before they get out of control. I can't tell you how many patients come see me in the emergency department when their drugs as an outpatient have failed and they have not talked to anybody. They don't even know to check these things. I ask them all the time. They have no clue. Well, that means that we're not educating those patients in the outpatient environment to understand this. It takes time, but we need to do that. Lastly, it would be things like shortness of breath. If they're not getting rid of fluid, then they're going to become more short of breath or have dyspnea on exertion or orthopnea or PND, especially if they have known heart failure. They can have more fluid volume in their legs, so the development of a pitting edema. That's from all fluid overload. What if they've over-diuresed the patient? Well, if their plasma volume is low, they're orthostatic, they can start getting dizziness, lightheadedness. I mean, it makes sense. They don't have the volume there so that when they go from sitting to standing, and gravity is now working against you and you don't have the volume, you just get a little lightheaded and get wonky with that change in position. So it becomes very relevant for us to consider it and monitor. All right. All right. So, whew, man, that's a lot. But guess what, guys? You are not alone. We are all colleagues. I don't care where you're at in your training. Whoever is listening to this, you're a student, a resident, or you've been a clinician as long as I have been. It's a lot to keep track of. But when you know why, then you can better master the how. What is the how? How to manage a patient. Ordering labs, counseling, monitoring. It's not just the what, it's how are you doing it for that patient sitting in front of you. If you understand why and you can articulate it to me or your colleagues, and you also know how to communicate to your patient, you're going to be more effective, in my opinion. Guys, we have other topic reviews like this. We consolidated them in collections, playlists to make it easy for you in doing reviews, studying, keeping up. So check us out at thisiswhy.health. There's downloads, some of the tables and things. If you need to use them for teaching purposes, bedside rounds, or you just want to study, or you just think it's helpful, I mean, go there and those are some downloads for people that are members. So check us out. Also follow us and subscribe or, on YouTube so that we can stay in touch with you. We'll also send out updates on new topics and resources that come available. Okay, so as we wrap up, loop diuretics, good medicines, been around for decades. We use them in the inpatient, outpatient environment. We have oral options, we have parenteral options. That gives us as clinicians a lot of flexibility. It also gives patients options, right? But they can also exert some effects that can go wrong. Electrolyte abnormalities, too much fluid loss. So there's a balance in all of this information. So I hope you found it to be useful. We'll see you again at the next topic. Take care.